So, shall we start, sir?
Sure, go ahead.
Yes. Okay, so good evening, everyone. I am Dr. Surbhi Dhupar, clinical pharmacist at Dinanath Mangeshkar Hospital, Pune, Maharashtra. And it's my immense pleasure to introduce and welcome today's speaker, Dr. Saidulu Ganta. He is clinical pharmacist at PD Hinduja Hospital, Mumbai. He is having 8 years of experience in different specialties of clinical pharmacy, which includes infectious diseases, ambulatory care and medication, therapy management, etc. He had 2 international certifications, one in AMSP and another in ASHP certificate in pain management. He was the speaker for 2 international conferences and 6 national conferences. He published his 4 papers and he is now co-PI for AMSP project by ISMR and research associate for antimicrobial antifungal stewardship by ISMR. He has interest in fundamental pharmacology such as pharmacokinetics and pharmacodynamics, dosing adjustment in organ dysfunction, and chronic drug monitoring. And he is going to present the today's topic, that is inhalational antimicrobials in mechanically ventilated patients. The next slide. So before we begin, there is participant guide. So for the questions, if you have any questions or queries, you can comment or mention your answer in the section comments below and submit your answers. So next slide. Submit your feedback and claim your certificate, but it's mandatory to join the FCPI website for claiming your certificate. And the next slide. And download your by joining the FCPI website. Now, without wasting the time, we are going to start our presentation, which is presented by Dr. Saidu Ganta. Over to you, Saidu.
Thanks, Surabhi, for the introduction. Today I'm going to talk on inhalational antibiotics in mechanical ventilated patients. So I don't have any financial disclosures, and please keep in mind this presentation focused on the aerosol dynamics and mechanical ventilator aspects of nebulizer antibiotic delivery, and it is not discussed detail on the clinical studies of nebulizer antibiotics in current practices. So points to discuss. Basically the reason we choose this topic. This is the topic very complex area where the clinical pharmacy is not much involved in anywhere in the world, and this is the area where we can improve the mechanical ventilation and inhalation antibiotic practices that can improve the antibiotic delivery. It can improve the clinical outcomes. So today I'm going to discuss that history of aerosol delivery, actually when it is this practice started, and what are the indications of antibiotics in the aerosol therapy, and how the antibiotics works in this kind of inhalational therapies, and what are the practical consideration when using these nebulizer antibiotics in mechanical ventilated patients, and what are the checklist for inhalational antibiotics, what are the prior important checklist when you are giving nebulizer antibiotic to any patient, and what is our role actually in ICU settings where you are giving this particular antibiotic as a nebulized, and what are the issues in the current clinical evidence and the further research opportunities in this area. Yeah, so the history, basically Pythia is known as the Oracle of Delphi. They started like inhaled emanation from the temple of Apollo. You can see the picture. they can use some emanation from the temple of Apollo to cure some certain kind of diseases. And the second one is the Claudius Galen is the physician to the gladiators in like centuries around, like centuries back, instructed his patients to breathe the fumes carrying the sulfuric acid from the Mount Venus to treat certain diseases. And he is the father of pharmacology and the founder of pharmacy as a science. His name is Pedanius Discrodius. Is initially prescribed the inhaled vapors for the in the first century to treat the different kinds of diseases. And this is the basic history. And in 1932, the word aerosol delivery coined by the Patterson, based on the air meaning the air and the sol meaning of the solution. Basically, it is a solution in the air. And the Native American shamans has harassing the psychotropic effects of datura to physician attempt to treat the tuberculosis with the inhaled iodine and sulfuric acid in 1930s. And after that, Tipanubreu first reported the diameter of droplets, which are very, very important to avoid the pharyngeal impactation. To like what is the actual size of the diameter required to reach the targeted site in that inside the lung. In the late 1940s and 1950s, the scientists are trying to attempts to use the aerosol neomycin and polymyxin, even penicillin G for the treating pneumococcal pneumonia. So this is the first area they started using the particular antibiotics in as an inhalation, as a nebulized in the form of to treat the different type of infections. And yeah, so what are the common indications for using these nebulized or inhalation antibiotics? The treatment of gram-negative lower respiratory infections like non-CF, non-cystic fibrosis, bronchostiasis, and ventilator-associated tracheobronchitis, and nosocomial pneumonia, and ventilator-associated pneumonia. In non-CF, we can use the Genta, Tobra, amikacin, and VAT, we can use the gentamicin and colistin. And nosocomial pneumonia, especially MDR GNB infections. And VAP, we can use a colistin, amikacin, ceftazidime as a nebulized antibiotics. And that is for the treatment part. If you come into the prevention of also gram-negative LRTS, you can use the colistin, ceftazidime. But all these indication based on some little bit clinical evidence. We don't have good evidence actually. And the placing of nebulized antibiotics in ICU. So when can use these nebulized antibiotic in ICU? When you suspect in the crab infection, or when you have a you have a more number of crab infection in your ICU, in a patient with a structural lung disease or lung transplant patients, you can use these nebulized antibiotics as a empirical or prophylactic therapy. But please note that it should not. This kind of practice is not well supported with any clinical data. So using these nebulized antibiotic, in particular these section of patients, like in individual case basis, not as a standard practice. And specificities of drug delivery. So basically lung have a very complex drug delivery, and if you see the from trachea to alveolar sac, it have around the 23 layers, and the airway bronchi roughly 16 to 17 times before the alveolar sacs are encountered. So this is from trachea, from alveolar sacs you have to 16 to 17 times of multiple layers we have. So reaching the drug from the trachea to alveolar ducts and sacs is very difficult. And if you see the aerosol delivery, basically we can use aerosols in the different infections like bronchial asthma and COPD. There we are using different nebulizers like metadose inhalers and jet nebulizers, ultrasonic and vibrating mesh nebulizers. But here the target is the bronchioles. Like this is the target bronchiole, very near to the trachea and very near to the entry point. But if in case of infections like ventilator associated pneumonia or hospital acquired pneumonia, the target is like alveolar sacs and alveolar ducts. So compared to that bronchial asthma and COPD, target site is the bronchioles, but infections we are targeting the alveolar ducts. This is the very distant site compared to the regular aerosols. So reaching here to the alveolar ducts and alveolar sacs, so very difficult to the reach this side, because this is a very complex delivery mechanism. It's a very minute area to reach the antibiotic properly. So the droplet size also very important to reach this site. Yeah, next slide. If you see, yeah. So if you give antibiotics for treatment of any like LRT infections, basically they have high extrapulmonary concentrations, and they can cause the potential toxicities. and they have a limited diffusion into the lung. Basically, if you see any antibiotics, they don't have good penetration like polymyxins, beta lactams, even with aminoglycosides. When you have a, like MDR, GNB infections, so these are the drug of choice for the systemic infection. When come to the like lung infections, when you're giving IV route, these drugs are not good choice because they are not reaching the drug site, particular target site like alveolar ducts or alveolar sacs, because they have some PKPD issues, because they have a lower concentration at the site of infection, can lead to the treatment failure. But in case of inhale, like especially nasal delivery, they can reach the higher pulmonary concentration at the site of infection. You can expect the like Cmax is a very high compared to the MIC. Your MIC is the required drug concentration is like 1,000, like 100 to 1,000 times of MIC. So this could be like very enough to kill the particular organism inside the lung, and it can cross the resistant emergent prevention threshold also, and works even in difficult to treat target, even if the organism is very like DTR organism also, you can treat with the inhaled antibiotics, because because of these inhalation rate, you can reach the antibiotic levels very higher concentration at the site of infection. So systemic side effects also you can expect very less, because we are giving through the inhaled route. And how, like, what is the concept behind that? If you see one example, for the gentamicin lung concentration, when you're treating MIC with the 1.1, so when you give gentamicin IV route, you can achieve the Cmax is a 1 mg per liter. But in same case, the same gentamicin, if you give the inhaled route, then it can achieve the Cmax is the 400 mg per liter. You can see the like, so the see the difference is the 400 times of the concentration differences. So this means like inhaled route achieve more Cmax compared to the IV route. And if you calculate the PD target, the formula is Cmax by MIC. So if suppose if I can apply the Cmax, IV Cmax, then 1 by, and MIC is the 0.1, then it becomes the target serum peak is the 10. If for the inhalation route, if I apply the Cmax is the 400 by MIC is the 0.1, then it is the 4,000 means. That means you can achieve the 400 times more above the IV route. So this is the like concept behind the nebulized antibiotic still works in this kind of infections. And can we use the inhalation antibiotics, which is the resistant culture report? Suppose you have a like sputum culture report, which shows the like carbapenem resistant Acinetobacter or carbapenem resistant Pseudomonas or E. coli, whatever. But you can still use the inhalation antibiotics because you are achieving the higher levels of antibiotics, higher levels of antibiotic at the site of infection compared to the IV route, because of we are giving through the inhalation route. So they are the Spanish antibiogram committee and recommending you can use the still use the nebulized antibiotic even in case of MDR organism. And coming to the practical consultation, optimizing the nebulized antibiotic delivery during the mechanical ventilation. So what are the things you can consider? Aerodynamics of the nebulizer therapy. So you have to understand the what is the dynamics of the aerosol during the nebulization process, and what are the minimum size of the particle size required to reach the target site, like to the target site means alveolar duct or alveolar sacs, and the type of nebulizers, which type of nebulizer can effectively help us to take our antibiotic solution to the target site. And during that mechanical ventilation process, we are using the circuit humidification and filters. These are the different filters. We are using the mechanical ventil settings, and how these filters and humidification process can affect the delivery of the antibiotic to the site of action, to the particular target site, and what is the drug concentration required to affect against these particular organisms, and what are the minimum requiring ventilator settings when you're using these antibiotics. And because this is very important, and most of the respiratory technicians or clinical pharmacists maybe not know about that, what are the ventilator settings we can required while using these nebulized antibiotics, and what are the some PKPD parameters we are going to discuss. So aerodynamics of the particle, if you see object with a greater mass have a more inertia. That means if you see the like a big size particle require more force to they require more force to change their motion. So this is the sum of the physics involved here. This is called impactation. The inertia of the larger particles is the law of motion. First law of motion will tend to settle by the impactation of the proximal areas of the MV circuit. The meaning is if you have a mechanical ventilator circuit, the proximal airways very near to the mechanical ventilator, If the particle size is very large, it can settle in the proximal airways only because of the whatever the pressure created by the mechanical ventilator. That pressure is not unable to move the larger particle to the patient lung side, like inside the patient lung. So because the particle size is very high and they have a more weight compared to the other particles. So the basically whatever the particles stays in proximal airways because of they have a larger weight. And the second one is the sedimentation, deposition of the some particles in the airways under the influence of gravity. So these are the particles not influenced by the impactation, but because of the gravity created by the mechanical ventilator, because of that some of the particles deposit in the patient airway and diffusion. And some of the smallest particles, these are the smallest particles, these are not influenced by the impactation mechanism, these are not impacted by the sedimentation mechanism. So because of the diffusion mechanism, these are the smallest particles, they can reach the alveolar sacs and alveolar duct. So the finally very smaller particles, uh, Brownian diffusion mechanism, which accounts for the dominant mechanism for the deposition of the alveolar region. So very smallest particle only reach the alveolar region. So if you see the particle size, if the particle size is 1 micron, then it can remove during the exhalation process. If the particle size is 1 to 3 micrometer, it can deposit in the alveoli, terminal bronchioles, and proximal bronchiole. See, so alveoli and terminal bronchioles, these are the not our target sites. So these are our target sites basically. Alveoli is our target site. And if the particle size is 3 to 5 micrometer, it can deposit in the distal bronchioles and lung parenchyma and some alveolar space by the sedimentation mechanism. But 3 to 5 also not a good particle size. 1 to 3 is the good particle size because our target site is the alveoli. Suppose if in case particle size is greater than 5 micrometer, then it cannot reach the target site like alveolar sacs or alveolar ducts. It can deposit in the proximal circuit of the mechanical ventilation or proximal lung airways, like into circuits or endotracheal tube and oropharynx or proximal airways. Because of they have a long particle, they have a long size and they have a heavy weight and they can impacted by the impactation mechanism. So ideal particle size is 1 to 3 or 3 to 5. So these are the good particle size to achieve the target site. So this means your particle is not less than 1 micrometer and not more than 5 micrometer. So if it is maintain the particle size 1 to 5, then you can expect your antibiotic can reach the target site. And so we are using the different nebulizers like jet nebulizer and jet nebulizer and vibrating mesh nebulizer. So if you see the jet nebulizer residual volume after giving inhalation antibiotic for after first cycle, then there still is so much amount of residual volume present in the jet nebulizer. This means like your antibiotic solution still left in the nebulizer only, it cannot reach the target site. But in the vibrating in jet ultrasonic jet nebulizer, some medium solution is present. But in the vibrating mesh nebulizer, you cannot. There is no much amount of solution present in the vibrating mesh nebulizer. Most of the like whatever amount you are using, like 5 ml or 10 ml or 2.5 ml, whatever amount, it entirely used by the each cycle. So there is no residual amount, and you can expect the maximum delivery of the uh, antibiotic to the target site. If you see the 40-60% of initial dose reach the target site compared to that jet and alter jet nebulizer. So this is the disadvantage of the jet nebulizer and alter nebulizer because of they cannot because they have a larger residual volume impact, and so they are not ideal choice for the mechanical ventilation antibiotic. And apart from that, and jet nebulizer is need to a compressed gas and the power source and potential interference with the ventilator. So this is the one of the disadvantage. But in ultrajet nebulizer and vibrating mesh nebulizer, there is no interference with the mechanical ventilator. And one of the disadvantages with the vibrating mesh nebulizer and ultrasonic nebulizer, that during this process they can create some heat. So because of the heat, the whatever antibiotic used by in this nebulizers, maybe these antibiotics can basically antibiotics are the heat degraded material, heat sensitive material. So they can degrade by the heat because of heat generation. They can degrade by easily. Then vibrating mesh nebulizer, some of the highly concentrated or viscous solutions may cause damage to the nebulizer. These are the particular disadvantage of these two nebulizers. And so like that is about the different types of nebulizers, and this is about what are the practical aspects of the nebulizer in the ventilator setting, where you can keep the nebulizer. Like so this is the patient side, and this is the ventilator side. So where you have to keep. So don't attach your nebulizer to the expirations wing. You have to attach to the inspiratory side. And if you see, so there is a bias flow. This is called like there are always some airflow from the ventilator to the patient side. It can generated by the every time 24 by 7. But if you keep the nebulizer very near to the, this is called Y piece. So this is called Y piece, very near to the Y piece, for about around 5 centimeter from the Y piece. Then so there is the basic bias flow not create enough pressure to move this nebulizer solution forward to the into the patient target side. I mean into the alveoli, because the bias flow create very less pressure. And also you are creating, there is no much space, and here is you can observe some curves. So in this what happened, because of these curve and because of these Y piece and the antibiotic solution not moved inside the inside to the patient lung side, it can move uh, to the because of some pressure generated by the patient side, that is called the expiration pressure. So because of this pressure, and because of there is no back pressure from the bias to the nebulizer side, and most of the whatever the aerosol loss can happen because of you can using the nebulizer very near to the Y piece. If in case if you fix the nebulizer very 15 to 40 centimeter from the, this is the Y piece, if you put the nebulizer 15 to 40 centimeter from the Y side, then you have a bias flow. And this bias flow can create some pressure, because initial bias flow have a some pressure, and it can create some pressure from the backside. It can help to move the nebulizer solution in this uh, inspiratory vent. It can help to move inside the patient lung. And especially in the during inspiration, see inspiration itself creates some pressure, so it can help to take the antibiotic solution inside the lung. And you have to every time check the whether nebulizer is placed 15 to 40 centimeter from the Y piece. So this is the important thing, take over from the slide. And uh, see, so if you use an nebulizer, like whatever the containing VM, like vibrating mesh nebulizer, so you have to close the expiratory filter. And so there is flow, this is the area you can put the vibrating mesh nebulizer, and there is a humidifier. It can help to uh, humidify the nebulizer solution. It can help to take the antibiotic solution from here to the Y piece to the lung. So during the inspiration phase, so positioning of the VMN close to the ventilator minimize the expiry waste and increase the bolus effect and increase the aerosol delivery. But use the VMN only in inspiratory cycle, not in the expiratory cycle. If you use the expiratory cycle, it can increase the all the antibiotic solution wasted to the expiratory filter. If you use the VMN to the expiration cycle, so use the VMN solution during the inspiration cycle only. Next, and yeah, yeah, this is the continuous simulation concept. If you place the nebulizer very near to the like 5 centimeter the Y piece, it can create the, because it can act by the vibrating mesh level, it can give the greater bolus effect. It can help to reach the more amount of antibiotic with the target site. But in the jet nebulizers, you can keep the nebulizer to the 15 to 40 centimeter from the Y piece. But in case of VMN and ultrasonic jet nebulizer, you can keep the nebulization very near to the Y piece to create the greater bolus effect. And it's not required. So basically, all the nebulizers suffer from the contribution of the humidity, and its ability increases as the because of this humidific nature of the ventilator settings. And these aerosol particles underwent the hygroscopic growth of the aerosol particles and potentially causing impact on the rainwater circuit. Because of this hygroscopic growth, they can deposit in the ventilator circuit and they can cause the rainout effect. So there is another setting called breath acute nebulization. So here we don't have any like no need to put like 5 centimeters from the YPs or 15 to 40 centimeter YPs. Here in the breath acute nebulization setting, just we can use directly nebulization after the YPs only. So it can create like more pressure. It can help to achieve the drug delivery to the target site very effectively and without loss. And there is no point like there is no expiratory waste of aerosol. You can see in the circulation in the previous nebulizers we can expect some kind of expiratory waste of aerosol because we are keeping the nebulization before the YPs. But in case of breathe acute nebulization, we are keeping the YPs, we are keeping the nebulizer after the YPs, so there is no waste of aerosol to the expiratory mechanism. And it is basically this kind of nebular system designed for the amikacin with within the respiratory range of less than 5 km in order to maximize the delivery to the deeper lung. So this system achieves to help the higher amikacin concentration in the epithelial lining fluid and tracheal secretion from the site of infection. So this basically this method aerolizes the lung during the 75% of the inspiratory cycle. So you can expect that within the first inspiratory cycle only you can achieve the 75% of the drug dose. And with the placement closer to the airway, it can at least the 25% of the inspiratory cycle pushes the aerosol deep into the lung without wasting the aerosol during the ventilative circuit. And if you see compared to the PDS and conventional vibrating mesh nebulizers and jet nebulizers only delivers the 10 to 18% of the drug, but the PDS system can deliver the 50% of the uh, nominal nebulizer dose of the drug. So the PDS, because of you are placing that nebulizer after the YPs, because of that it can deliver the most of the drug compared to the conventional jet nebulizers. So if you see YPs should be directly connected to the proximal tip of the endotracheal tube. Yeah. So this is the white YPs, and see we are connecting to the ET tube. So this is the YPs and this is the ET tube. Yeah. Yeah. How to give antibiotic? Addition of antibiotic solution in the mechanical ventricular setting. So this is the way we can add the antibiotic solution. So basically, this is the Y-piece you connected to the tracheostomy tube, and after connecting the tracheostomy tube, you can add the antibiotic solution. And so, what is the rain effect? Rainout effect means visual infection of the cloud of the nebulization delivered to the distal tip of the inspiratory limb. It can help to whether is there any like possible nebulizer malfunction, which can commonly seen with the jet nebulizers. Basically, it is a cloud precipitation of the aerosol antibiotics. If it is there any like malfunction of the jet nebulizer, you can see the cloud delivery of the aerosol delivery because like it is like malfunctioned jet nebulizer. You can observing some like cloud delivery of the aerosol in white patches. See, you can observe it. So this means like there is no uniformity distribution of the nebulizer medication. The cloud nebulization, there is some defect in the nebulizer. Because of that, it's happening. Yeah. So this is called the Raynaud effect. So because of that, you cannot expect maximum delivery to the target site. Yeah. Yeah. So we saw everything about the different types of nebulizers and how to administer the nebulized medication. Then after nebulization, what are the common side effects you can observe? Like some patient may undergo like hypoxemia due to the manipulation of the circuit and placement of the nebulizer and specific ventilator circuit and change of filters and suctioning. Because of all these reasons, patient may went to hypoxemia. So no need to worry about something like if the hypoxemia happens, then we go and change the ventilator setting again, or we can think that like ARDS, or we can start like maybe new antibiotics like that because of hypoxemic conditions. Because basically this is the reasons you can expect the hypoxemia during the nebulization. Uh, if the hypoxemia happens in the asthma and COPD patient, you have to take care of caution that, and you have to maintain. You have to avoid the FiO2 and FiO2 ratio less than 200. You always maintain the ratio greater than 200 to prevent the hypoxemia in especially asthma COPD in ARDS patient. And sometimes patient may experience cough and bronchospasm because of the larger particles they may be dislodged in the proximal airways, and because of that patient might they can create some bronchospasm and they can trigger the cough reflexes. This is the reason my patient experiences cough and bronchospasm. And especially you can avoid the hypotonic solutions, try to give isotonic solutions. And occlusion, deposition of the larger aerosol particles in the expiratory circuit. And so because of that sometimes the expiratory circuit maybe not work, and you have to check frequently whether there is an occlusion happening in the expiratory circuit. And if the occlusion happens, you can expect the increase in the peak airway pressure. If you observe in the mechanical ventilator setting, is there any increase in the peak airway pressure, please check is there any occlusion or any blockage in the expiratory ring. And caution of the nebulized cholesterol IHD and heart failure patient. Yeah, especially when using nebulized colistin, especially in IHD and heart failure patient, it can cause similar kind of side effects. And you have to do inspect and change the expiratory filter after the each nebulization. So this is the one of the recommendation, but it's not practically not possible every time. For each nebulization, it's not possible to change expiratory filter. It also costly also. And sedation related complication. So before giving nebulization, we are practicing sedation in ICU anyways. So myopathy, delirium, deleterious hemodynamic side effects. And so this not the sedation related not related to the nebulized antibiotics, related to the sedated medications like benzodiazepines. So try to use the short acting agent so it doesn't cause much side effects. And nephrotoxicity, because of if in case you can use the nebulized colistin or amikacin, they have a systemic circulation from the like from the target site to they go into the blood circulation, they can cause some systemic side effects because of increased permeability of the alveolar capillary membrane and during the lung tissue inflammation. So especially caution with the aminoglycosan low, and we cannot expect with the colistin, but you can expect with the aminoglycosides. If in case like you don't have any explanation for the increase in the serum creatinine, maybe you can think about this because of this only. And there is no sometimes when you're using inappropriate concentration, they can trigger the emergence of bacterial resistance, but we don't have good evidence on this. And sometimes there is concept called the sputum antagonism. The sputums contain some active binding mucin proteins that can prevent the antibiotic delivery to the target site. Before giving nebular antibiotics, you can try to clear the sputum. Is there any sputum inside the patient lung and airways? So you can do the mucus plug clearance before giving the nebular antibiotics. Otherwise, it can affect the antibiotic delivery physically. So these are the common nebulized related side effects and management aspects. And yeah, so strategy related to the ventilator and place the filter on the expiratory limb before the flow meter, and change the expiratory filter after each nebulization. And if you are using any heat and humidification, please stop the humidification and heat in the ventilator setting. Otherwise, it can cause hygroscopic growth of the aerosol particle of the antibiotic. It can deposit in the proximal airways. You cannot expect the good delivery. So don't please stop the heat and humidification during the especially nebulized antibiotic timings. And if in case the patient have thick secretions, maybe you can give some time and you can stop and minimize the disconnection of the circuit, particularly in patients with severe hypoxemia. So if you use like every time you keep changing the ventilator settings, it can worsen the again hypoxemia. It can lead to some ARDS conditions. So try to changing the ventilator settings as much as possible. And strategy related to the monitoring, and monitoring the peak pressure, especially in asthma, COPD, IHD, and heart failure patient. So increasing the PEEP may be indication of there is some obstruction in the expiratory filter. So if you observing during the mechanical during the nebular antibiotic, if you observe any peak increase in the peak, or you can talk to the respiratory technician, or you can instruct your nursing colleague, ask them to observe is there any increasing the PEEP value during the nebulized antibiotic. then ask them to check that expiratory filter. Is there any occlusion? Then ask them to change it filter immediately, and monitor for the bronchospasm. And sometimes we recommend using some nebulized solutions like albuterol and salbutamol, something like that, to relieve the bronchospasm, and especially patient with high risk, and to prevent the bronchospasm. And if the patient have mild bronchospasm, just withdraw nebulization, just give the local bronchodilators before following the nebulization. This is the one of the good practice. But if even the patient still have bronchospasm after giving the bronchodilator also, it better to stop the nebular antibiotic completely, or you can change the route of administration. So better don't give nebular antibiotics if you like observe any severe bronchospasm. So these are very, very important things. These are like no one monitor these things, especially in ICU settings. We think like because of some other reasons, bronchospasm happening, some other reasons, peak level is increasing. But you can think like all the nebulous antibiotic can cause all these things. If you know all these things, just please like monitor during your rounds. And oxygenation during the nebulization process. Ensure the correct level of sedation. Low dose of propofol you can use, and avoid like asynchronous with the ventilator. I mean, use the minimum ventilator settings, and try to use the midazolam instead of propofol. Can be used in the hemodynamic unstable patient, because propofol can cause more mechanical ventilator asynchronous. And if sedation is increased to ensure patient coordination with the ventilator, it should be withdrawn to the end of the nebulization. So most of the time they forgot to withdraw sedation, and it can lead to some side effects. So particularly if the patient nebulizer antibiotics, if the patient require any sedation, just keep it very minimal duration. Don't prolong the nebulization. Don't prolong the sedation to avoid the like systemic side effects of the related to sedation. And always avoid the tidal volumes 8 ml per kg in patients with severe ARDSs. Try to maintain the minimal tidal volumes. Avoid increasing the auto PEEP in patients with the high airway resistance like asthma COPD patients by maintaining the enough expiratory time. And avoid delay in administration of nebulized antibiotics. Just prepare like immediately and give the antibiotic. Don't wait for like so much time to administer antibiotics, especially in case of nebular antibiotics. It converted into the CMS. It can get severe respiratory side effects. There are some FDA reports. Patient is died because of they are waiting so much time after reconstitution. They administer this coalition antibiotic. They can create some deaths in some patients. And so when you are in a rounds, what are the checklists for that this nebulized antibiotics? Ventilatory mode. So always use the volume control mode rather than the pressure control mode. This is very, very important. If you don't use the volume control mode, you cannot expect proper delivery of the nebular antibiotic to the target site. And maintain the constant inspiratory flow. Don't change inspiratory flow, because if you change inspiratory flow, it can affect that it can change the pressure, and it can affect the delivery of the nebulous antibiotic solution to the target site. And ideal ventilatory parameters: guided volume 8 ml per kg, and maintain the respiratory frequency 12 to 15 beats per minute. Inspiratory expiratory ratio around less than 50% always. And end respiratory pass 20% of the duty cycle. And the total respiratory cycle, end respiratory pass is only 20%. And PEEP value 5 to 10 centimeter HO2. You have to maintain this value. And if it is increasing the PEEP, that's please check the expiratory limb for occlusion. And avoid the sharp angles, because if you have a sharp angles in the ventilator setting, it can affect that aerosol delivery. Maybe it can because most of the larger particle by the impact and mechanism, maybe they can dislodge in that particular starting area only, in the proximal settings only. They cannot go further forward because of the particle size and weight. And rough inner size spaces in the ventilator settings. And avoid asynchronous and triggering. So try to use the shorter sedation if the patient have any asynchronous. And increase the level of sedation if necessary. Removal of the heat and moisture exchanger during the procedure. And stop the heat humidifier during the nebulization. Change expiratory filter after each nebulization, what we discussed like previously. Yeah. So inhaled PKPD modeling difficult because of aerosol deposition. It is a patient-specific respiratory tract physiology because every patient have a RA physiology is very different, and it depends on the product-dependent variables such as the emitted dose. Like different nebulizers emitting the different doses. If you use the jet nebulizers, deliver only 10%. Ultrasonic jet nebulizers deliver only 20 to 30%. EVM deliver like 40 to 60%. PDS delivering the 60 to 70%. So it depends on the which type of nebulizer you're using, and depends on the particle size also and the device resistance also. And the particle dissolution depends on the isotonicity. If you use the hypotonic solution, it can cause a bronchospasm. If you cause hypertonic solution, it can cause hypoxemia. So always try to use the isotonicity and the neutral pH solutions. Don't use acidic solutions and alkaline solutions. Both can cause side effects. And your osmolarity should maintain that 15 to 200 ml per meter. And sometimes the chloride ions required for the diffusion. And but if you use the chloride ions in that particular antibiotic solution, sometimes it can cause severe side effects like bronchospasm and hypoxemia. And some and misinterpretation of the ELF concentration. Basically, higher ELF concentration may not always reflect that higher antibiotic concentration because it is more branchial rather than the alveolar intestinal concentration because ELF is very closer to the bronchi. So even if you have a higher epithelial lung fluid concentration, doesn't mean that patient have a good concentration at the alveolar site or interstitial concentration. So both are the little bit different target site. Uh, and antibiotic physicochemical characteristics also like very important. And molecular weight, larger weight favors for more diffusion, and the positive charge molecules very they are more favor for the diffusion, like tobramycin. Other beta lactams have negative charge molecules, that's why we don't expect good results with the beta lactam antibiotics. And lipophilicity, if you have a good lipophilic antibiotic, they can easily cross the membranes. And the lipophilicity and positive charge molecules and the molecular weight, these can also influence the delivery of the inhaled antibiotic. Yeah. So why current inhalation antibiotics are failed in the randomized control trials? If you see the what are the IDS guidelines, what are the like the different guidelines, they recommend there is no role of nebulizer antibiotics in the treatment of MDR JNB infections because of there are some standard reasons. We are in the nebulized colistin because of the reason the colistin failed because of prodrug conversion, and the colistin have unpredictable PKPD in the lung parenchyma. You don't, I mean, in vivo in vitro drug levels, there is like discrepancy between in vivo and in vitro drug levels, and it can cause colistin can cause alveolar damage. It can create so many side effects because of the cyclic cation peptide can damage alveoli. It can affect the delivery to the lung and testis. And aminoglycosides, they can affect the sputum antagonism because sputum antagonism contains some mucin proteins. They can antagonize the aminoglycoside activity. And aminoglycosides basically these are like hydrophilic antibiotics, and they can mostly uh, reach up to the ELF, but they cannot reach the alveolar sacs and interstitium. And sometimes ELF contamination also may be misleading that higher ELF concentration we can expect the higher AMG levels, but sometimes ELF also lead to the misinterpretation. And we don't have any standard dosing. All came from by like some like expert recommendation, but we don't have any standard evidence like for aminoglycosides. And the problem is aminoglycosides have a positive charge molecules. As I discussed earlier, this positive charge antibiotics can easily diffuse into the uh, alveoli and the blood barrier. They can easily transfer from the alveoli to the blood, and they can usually cause the systemic toxicity. So this is the one of the biggest advantages of the nebulizer antibiotics. And cephalosporins they require because they have a short half life, and basically hydrophilic antibiotics, and that uh, to have like good therapeutic effect, you require the cephalosporin need to be administered very frequently. And the problem is uh, our rapid airway, they have a like we have a rapid airway clearance because our airway mechanism is very powerful and they easily clear the cephalosporin antibiotic from the circulation, and the lack of permanent iron like chloride ion is not available in the ceftriaxone like beta lactam antibiotic solutions. Because of this, these are the like hydrophilic antibiotics. They don't have a lipophilic nature, and mostly these are the like deuterion or positive charge molecules. Because of this, they are unable to crosses the membranes, and they can sometimes they can cause so much cough because they can because of the molecular particles like deposit in the proximal areas of the lung, they can create the cough. And and the carbapenems severe allergic, they can cause severe air allergic reactions. So because of these different reasons, these are the one of the main reasons uh, we don't have a good inhalational antibiotics, and this is the one of the reason they are failed in the RCTs. So that's how like we can see the negative recommendation for inhalation antibiotics. And issues in the current evidence and the future research opportunities, because we have whatever the RCTs published till now on the nebular antibiotic RCTs and the treatment of MDR GNB, and there is a significant source of heterogeneity among the published studies. So basically, the compounding factors and methodological insufficient present in the RCTs, because different RCTs using the different methodologies, and they have so many confounding factors. They are not addressed properly, and they are using very two sample results are very small. It's not up to like to identify the differentiation between that nebular antibiotic versus non-nebular antibiotics. And inconsistencies in the clinical definitions for the diagnosis of the infection of its resolution. Because if you see like any literature, still there is no standard definition for the VAP and HAP and like nosocomial pneumonia, hospital pneumonia, and ventilatory associated pneumonia, ventilatory tracheobronchitis. Although we have a definition for the surveillance purpose, but the clinical purpose we don't have any standard definitions. So because of this, that depends on the clinician choice, and depends on the institutional policies, and they can recruit the patient with the different kind of like respiratory tract infections. But actually, we don't know whether that patient truly have like a HAP or VAP. Maybe some patient don't have any HAP, some patient maybe have HAP. But because of there is no standard definition, we recruiting the different kind of patients. Maybe that can affect that results of the outcomes of the like RCTs for the current recommendation. And the mixing VAP caused by the susceptible and extra GNB. So whatever the RCTs published in that RCTs, we have like they in that population, we have a susceptible bugs, and we have XDR GNB bugs, and they're using the multiple antibiotic regimens rather than the monotherapy. So suppose they're using the different antibiotics like minocycline, like polymyxin, amikacin, colistin, meropenem. So in the same patient, they're using the multiple antibiotics. So it's very hard to like it's very difficult to say to extrapolate which antibiotic can give the clinical outcome, giving the clinical outcomes, or which antibiotic, because of there is the multiple antibiotics. And distribution of the nebular antibiotic through the different segments of the lung remains unclear, because we already know the lung physiology is very complex, and from trachea to the alveolar sacs, it's around like 23-24 layers are there, and most of the antibiotics are the hydrophilic antibiotics, and there are some like in vitro in vivo PKPD modeling difficulties. We don't have good modeling PKPD to define the proper PKPD target for in this particular administration route, and lack of specific and safety evaluations, and standardized administration of techniques. And we don't have a very good naval delivery techniques. We already saw we have a, like different nebulized admission techniques, but those nebulized mostly meant for that administration of bronchodilators, and the bronchodilators are delivery near to the trachea, but they are delivered near to the bronchi, not to the alveolar sacs. And we don't have any golden or good like delivery techniques of nebulized antibiotics. And the impact of nebulized antibiotic therapy on the lung and airway microbiome, and whether like we are giving high dose of higher concentration of antibiotic to the lung and airway, but how it is impacting the already existing airway microbiome, and whether it can it can create any emergence of resistance, and maybe it can create another super infections. We don't have any data on this, and we don't have any literature on this. And so these are the basic current issues in that nebulized antibiotic practices. And so, what are the further RCT opportunities in this area? Conducting RCTs under the substitute strategy for the treatment of FAP caused by the uh, MDR gene is a priority. So, whatever the RCTs, in that current RCTs, we are using IV, IV antibiotics along with we are using the nebulized antibiotics. We never comparing nebulized antibiotic versus IV antibiotics. We never compare the nebulized antibiotic versus without nebulized antibiotics. Whatever the trials already, whatever we have IV plus nebulized antibiotics. We never do like uh, non-inferiority or superiority RCTs. We have only substitute strategies. So in the non-inferiority RCTs, compare the inhaled polymyxin aminoglycoside to intravenous cephalosporins or beta-lactamase inhibitors, and the superiority RCTs, patient with a VAP caused by the exterior DNB, compare with the short course of inhaled versus systemic. So in the superiority, you can compare the inhaled versus systemic. In non-inferiority, compare that inhaled antibiotics to IV antibiotics. That's it. So thank you. Next presentation is the de-escalation escalation of antibiotics by Radhika Krishna Kumar on 19th May 2024 Sunday 5 to 6 p.m. Please attend. And next coming antimicrobial dosing on renal hepatic impairment by Aisha Sana on May 2024 from Monday to 8 p.m. to 9 p.m. This is the cycle to presentation time. And basic module in critical care medicine, cycle 1, presentation 7. And the rapid sequence intubation in May 23-24 by Harita Rajakrishnan, 6 to 7 p.m. And another my presentation cycle to presentation 3, antimicrobial loading dose and maintenance dose on 25th Saturday. And basics of evidence-based medicine part 2 by Mohammed Rashad, and on May 27, 2024. Antibiotics intravenous to oral switch May 30 by Arya Kumar S. Famdi on May 30. Thank you.
Thank you. Thank you so much, sir. I think you have explained all the answers to the suspected questions that pop up in my mind. Actually, I have still one question, that is how effective the nebulized therapy in your practical experience?
Sorry, I didn't get your question.
How effective the nebulized therapy? Like you are seeing the daily ICU patients, in that, how effective the nebulized therapy?
We don't use regularly as a standard of care in our ICU settings. Maybe we'll try in couple of patients. We see good outcomes actually. We try
Okay.
to apply all these ventilated settings. We go to the respiratory technician. We speak to the nurses. We speak to the intensivist, and we sit there and we'll try to whatever the available ventilator setting. We try to optimize the ventilator settings, and we try to give like nebula like bronchodilators before the nebula antibiotics, and we optimize the tidal volume, PEEP settings, and we maintain that 15 to 40 centimeters from the YPs, and we stop the humidifier. So we try to maintain all the ventilator settings, and in couple of patients, we see the good clinical outcomes. And the one best thing is we don't see much MDR crab and MDR pseudomonas in our ICU setting. So that is one of the advantage. That's why we are not using much nebular antibiotics. Still, I can believe they have a good role in treatment of these infections, because there is like solid evidence that if you give inhaled antibiotics, nebular antibiotics to the inhaled route, they are achieving the like 100 to 1000 times of the MS of the particular organism. So this is the enough evidence to telling us like nebular antibiotics definitely work. But the problem is we have some like methodological issues in our RCTs, and we are not have a good administration techniques. Because of that, all the RCTs failed. All the RCTs result shows that nebular antibiotics are not working properly.
Right. Right, sir. Thank you. Thank you so much, sir. I think that's the end of the session. Thank you for joining. And you can claim your certificate by joining the FCPI website. Thank you. Thank you, Zaidul, sir.
Yeah.